Thank you very much, and good evening. It's truly a pleasure to be here with you this evening at this extraordinary time in the evolution of HCV therapy. I'd like to thank Projects in Knowledge for inviting me and my esteemed colleagues to participate in this symposium. I'd like to introduce the distinguished faculty on stage with me this evening. First, Bruce Bacon, Professor of Internal Medicine, Department of Gastroenterology and Hepatology at St. Louis University School of Medicine. Nancy Rowe, who is an Associate Professor in the Department of Medicine at the University of Chicago. And Sherilyn Brinkley, Nurse Practitioner and Program Manager in the Infectious Disease Department at Johns Hopkins University in Baltimore. There's been some activity on Twitter during the past few weeks regarding this discussion tonight, and we hope to continue getting your comments and questions via text or tweets. Please watch the screen for the hashtags and text numbers to use, and please let us hear from you. We'll try to be as responsive to your questions as possible. In addition to the abundant information we've prepared for you this evening, I'd like to point out that the mobile app on hepatitis C that Projects in Knowledge has made available in the App Store. You may have noted on the slides shown prior to this presentation that you can text HCV to 313131 to receive information on getting this free app. And now let's begin. This is the evolution of hepatitis C therapy, shown since 1991 with the introduction of interferon, and how the field has accelerated in the last several years. In 2011, we had a revolution on our hands with the introduction of telaprevir and boceprevir, the first protease inhibitors used with interferon and ribavirin to treat genotype 1, but it was around the same time that we had a proof of concept, which was historic, that you could cure hepatitis C without interferon, something that had been much debated over many years. And then rapidly, in the next 2 years, we learned that not only can you cure hepatitis C without interferon, but apparently that we can achieve such a goal most, or perhaps even ultimately, all of the time. In late 2013, there were two historic developments: the approval of Simeprevir in November here in the United States, a protease inhibitor, approved for use with interferon and ribavirin for genotype 1, and Sofosbuvir in December, also approved for use with interferon and ribavirin for genotype 1, but also approved as the first foundation for oral therapy, that is Sofosbuvir and ribavirin, for patients with genotypes 2 and 3. We await the possible introduction of additional agents this year, including, possibly as early as this fall, extraordinary combination regimens that will achieve the kinds of SVR rates that we could only dream of up till only a couple of years ago, even more recently than that. And I kind of depict the achievement of near universal cure rates in hepatitis C genotype 1 patients as the holy grail on this slide. Based on the elucidation of the life cycle and biology and structural proteins, as well as non-structural proteins of hepatitis C, there have been an extraordinary constellation of validated drug targets that have been developed. And many of you are familiar with the different classes, most notably protease inhibitors, NS5A or replication complex inhibitors, and nucleotide polymerase inhibitors, as well as non-nucleotide polymerase inhibitors based on where those agents bind on the HCV polymerase molecule. We can't possibly cover all the drugs that are shown here. I simply want to convey a flavor of the sheer number of drugs that are in various stages of approval or earlier in development. There have been a number of other exciting concepts, including host factor antagonism, but one of the questions we have to ask at this juncture in mid-2014 is what the future of some of those more novel ideas, like cyclophilin antagonists or entry inhibitors and others, will be, given the kinds of results that we're about to achieve, and in fact have already started to achieve, with approved or nearly approved therapies. And we'll talk about that. One of the driving concepts that has led to this marked acceleration in the evolution of hepatitis C therapy has been the ability, in terms of treatment duration, to compress the accordion of treatment in HCV drug development, from the traditional 48 weeks of therapy with interferon-based therapy and then the usual follow-up for 24 weeks to achieve SVR24 data, only then being able to go on to the next phase of drug development or submission to regulatory agencies. We've now compressed that accordion to as little as 12 weeks, and in fact some investigators are looking at even shorter durations of therapy with combinations of potent antiviral agents But 12 weeks is the focus of many of the recent data, and then to some extent shorter than that. And then another important development has been the establishment of a new primary endpoint in our trials, and indeed in practice, SVR12 instead of SVR24, because of the very, very high concordance rate between the patient's virologic status 12 weeks after the end of therapy and their status forever after. So in other words, if you're negative at 12 weeks after the end of treatment, nearly all patients remain so. Of course, victory is not the same as closure, and we do need to continue our follow-up of patients after SVR12, though there's some debate and variability in practice as to how long we should do that. But it's this compression of the duration of therapy and the duration of follow-up required to reach one's primary endpoint that has helped catapult us into the remarkable era in which we find ourselves now. With that, I'd like to invite Bruce Bacon to give a talk on the state of the science in HCV therapy. Bruce?
Thank you, Ira. I, too, would like to thank Projects and Knowledge and you for allowing me to work up here with you. This is a good opportunity, a lot of fun. So we're going to quickly go through some slides. We have a few slides to go through. First of all, the prevalence of hepatitis C in the United States. I think you're all familiar with this and have seen variations of this slide, but it's estimated that about 3.2 million people are chronically infected. This is based on NHANES data that was presented about 10 to 12 years ago. And the important thing that's been demonstrated over the last year or two is the fact that 70% of the individuals that are currently infected in the United States, harboring at least half the people that don't know they've got hepatitis C, were born between 1945 and 1964, the so-called baby boomers. Ira and I are baby boomers, and I've been tested for hepatitis C. I don't have it. You too? Okay, that's good. As I said, only about half of them have been diagnosed. And the number of chronically infected can be even higher because these various populations weren't sampled in NHANES: the incarcerated, the homeless, nursing home residents, hospitalized, those on active military duty. So if you look at some of those populations, it's likely that there are more patients with hepatitis C than we know. And I've seen some estimates up to 5 or 6 million people. The other thing that happened last year was the updated by the United States Preventative Services Task Force for screening recommendations. And the CDC had recommended that all baby boomers be screened, a one-time screening, and the USPSTF came along and gave this a grade B designation. What that means is it's strongly advocated that patients born between 45 and 65 be screened, and that there will be insurance coverage for that screening. So all of you should be screening. I hope all of you are screening those baby boomers. So why do we treat hepatitis C? Well, it's a chronic disease. It's common. It's potentially progressive. We know the complications are becoming much more common with more and more patients that we see in our practices with liver failure or with hepatocellular cancer. And we know, as we heard from Dr. Jacobson, the cure, or SVR, is achievable in increasing numbers of patients. And we also have learned that SVR is associated with improvement histologically, regression of fibrosis, lower risk of liver failure and hepatocellular cancer, and improved survival. And as little as 10 years ago, we really didn't know this as conclusively as we do now. We knew it intuitively from our experience, but we didn't know it from properly done trials, and now we do. Now, these are a table of the recently approved treatments for hepatitis C. Ira mentioned Simeprevir and Sofosbuvir in November and December of last year. And they were approved as a part of an antiviral treatment regimen with pegylated interferon and ribavirin, both of them. Simeprevir with peg-ribo for 12 weeks, followed by 12 weeks of peg-ribo, and Sofosbuvir with 12 weeks of peg-ribo. If any of you that are interested in hepatitis C haven't found the treatment guidelines that are in the AASLD, that are in hepatology, earlier this year, you should take a look at this. This is a joint effort between the AASLD and the Infectious Diseases Society of America to rapidly publish recommendations and guidelines, I guess guidelines would be the best word for it, for using these new drugs that are coming off the market, coming into the marketplace quickly. So for interferon-eligible patients, the recommendation of the guideline is Sofosbuvir plus PEG-RABA for 12 weeks. For interferon-ineligible, it's recommended Sofosbuvir, Simeprevir, plus or minus Ribavirin for 12 weeks. That's for genotype 1. For genotypes 2 and 3, it's Sof and Riba for either 12 or 24 weeks. For genotype 4, if they're interferon eligible, we don't see many 4 patients, Sof and PEG-RABA for 12 weeks. And then for genotype 5 and 6, we see fewer of, Sof and PEG-RABA for 12 weeks. So this is for naive patients. For treatment-experienced patients, where previous treatment has failed, the recommendation for genotype 1 patients is Sofosbuvir and Simeprevir plus or minus Ribavirin for 12 weeks. For genotype 2 and 3, it's the same as I just mentioned, and for 4 and for 5 and 6, it's the same. So the only thing that changes with these guidelines for treatment-experienced patients is the consideration of soft sim. So this is what we have now. These are the treatment combinations for hepatitis C that we have available to us today. We have Sofosbuvir with PEG-RABA. We have Sofosbuvir with Ribavirin for genotype 2 and 3, and also for some genotype 1 patients. We have Simeprevir with PEG-RABA, and we have Simeprevir and Sofosbuvir. And I must point out to you, the first 3 regimens are all FDA approved as regimens. The last, Simeprevir is approved, Sofosbuvir is approved, but they're not approved together by the FDA. Now, there's differences of opinion as to whether or not that makes much difference, but just so you know, that's the way it is. So a little bit about Sofosbuvir. As Ira said, it's a nucleoside polymerase inhibitor. It has antiviral activity against all 6 genotypes. It's easy to take. It's 1 pill daily, no food effect. Remember all the high-fat diet you had to do with the Simeprevir? We don't have to do that anymore. No known drug-drug interactions. That makes it pretty easy. And these are the various studies that were completed as phase 3 trials that led to approval by the FDA last year. The NEUTRINO trial, the Fission, Fusion, Positron, and the VALENCE trial. I don't know, they pay people a lot of money to cook up these names, and so at least they kind of follow a theme. So NEUTRINO was with genotypes 1, 4, 5, and 6. Fission, 2, 3, treatment naive. Fusion, 2, 3, unresponsive to prior treatment, and compared with 16 weeks, 12 weeks compared to 16 weeks. Positron was for patients ineligible or intolerant, and I sometimes add or unwilling to take interferon-based therapy. That was compared to placebo. And then VALENCE was a European study that looked at longer duration of treatment, particularly to find out if longer duration of treatment for genotypes 3 would be successful. Now, the NEUTRINO study, as we said, is Sofosbuvir and PEG-RABA for 12 weeks. Another thing that's a breakaway from what we did with Simeprevir and Boceprevir, there's no response-guided therapy. These are just fixed regimens. You decide what you're going to do and stick with it. You don't have to make further decisions along the way. It's for patients genotype 1, 4, 5, and 6, treatment naive, was studied treatment-naive patients. 17% compensated cirrhotic, 17% African American or Black, and 29% had IL-28B genotype CC. What we're finding is that the importance of IL-28B genotype, race, or ethnicity are not as important as they were with interferon-based or prior to these regimens. And the regimen was Sofosbuvir 400 milligrams a day with Ribavirin and weight-based dosing, 1,000 milligrams for less than 75 kilograms, 1,200 milligrams for more, and Pegasus at 180 mics per week. And these are the results. These are truly startling results. So this is the NEUTRINO study. First of all, greater than 90% of patients have undetectable virus after 2 weeks of treatment. And those patients go on to achieve an SVR. So total, you put everybody together in week 12 post-treatment. So the SVR 12 was 90% for all of those patients together. So you see there's a little bit of drop-off, a little bit of relapse from week 12 to week 12 of follow-up. This just shows the data, subs it out a little bit differently. If you just look at the genotype 1 patients, it's 89%, 1A 92%, 1B 82%. Genotype 4, there was only one patient that didn't respond, so it was 27 to 28 or 96%. Genotype 5 and 6, there were only 7 patients that were identified in the trial, but every single one of them responded. So on the off chance you see a 5 or 6, you could feel comfortable treating that patient with Sofosbuvir, PEG, and Riba, and it's high likelihood they would respond. As you can see, race didn't make much of a difference in terms of response rates, but cirrhotic patients didn't do as well as non-cirrhotic, and that's something that carries through all the way as we go through these various trials. So the conclusions of the NEUTRINO study were that 12 weeks of Sofosbuvir, PEG, and Riba achieved 90% SVR in treatment-naive patients with genotypes 1, 4, 5, or 6, and that 99% of patients had HCV RNA levels less than the lower limit of quantification by treatment week 4, in other words, an RVR, and all virologic failures were due to relapse. In other words, there were no on-treatment virologic failures. There were no patients that had what we called breakthrough in the past. The only patients who didn't achieve an SVR were patients who relapsed. Safety, treatment discontinuation due to AEs was very unusual. Patients tolerated this very well. The rates of serious AEs were low, and the most common AEs were headache, fatigue, nausea, insomnia, and anemia. Maybe some of you who are on treatment are fighting their insomnia now by listening to this lecture, you see. I hope not. Okay, now, the genotype 2 and 3 studies. There are a lot of studies that were done with genotype 2 and 3. And I think it's because they had to decide in terms of regimens how to handle the genotype 3s, because the first data that came out of these studies were not very robust. So fission is treatment naive, fusion is treatment experienced, and positron is those patients who were intolerant to interferon. So the design here was Sofosbuvir and Ribavirin for 12 weeks, PEG and Riba, standard of care, for 24 weeks. So in fission, in fusion, which is treatment experienced, it was Sofosbuvir and Ribavirin for 12 weeks. Now looking at Sofosbuvir and Ribavirin for 16 weeks, again, to see if you could find a way to get the genotype 3s to do something. And then the positron was just Sofosbuvir and Ribavirin for 12 weeks. And the results are shown here. This is kind of a busy slide. I'll guide you through it and point out what I think is most important. I'm not going to look at the overall data, just look at the specific genotype 2 and genotype 3, which are the middle columns and the right-hand columns. So for genotype 2, with Sof and Riba, it's 97% of patients were cured. With the treatment experienced, it was 86%. With the interferon intolerant, unwilling, it was 93% for genotype 2. Remember, that was placebo, so placebos were right down here. Fortunately, none of the placebos responded. That would create a problem. In the genotype 3, it was a little bit different. So here, the Sofosbuvir and Ribavirin for 12 weeks was just as good as PEG and Riba for 24 weeks with genotype 3. And you sort of say, well, what's the big deal? Well, first of all, it's 24 weeks, not 12. And secondly, it includes interferon and the side effects thereof. In the fusion study, the investigators started to figure this out a little bit better. And remember, Sofosbuvir and Ribavirin were for 16 weeks, and there the results are a little bit better, up to 62% for genotype 3. Still not quite like what you get with genotype 2, but better. And Sofosbuvir and Ribavirin alone for 12 weeks was really quite poor, at only 30%. And in genotype 3, this was for 12 weeks. I don't know why there was a difference between here and here, but those are the observations. So then was the VALENCE study. The VALENCE treated patients either for, if they were genotype 2, they treated patients for 12 weeks. If they were genotype 3, they treated patients for 24 weeks. And now we see how to treat genotype 3. A longer duration of therapy is what's necessary. So this is Sofosbuvir and Ribavirin for 24 weeks with an 85% cure rate. Genotype 2 patients, just for 12 weeks, 93%. So what you see from all of these studies is the longer the duration of treatment for genotype 3, the better the response. And for genotype 2, you're better than 90% with just about all of these regimens. So genotype 2 is well taken care of with just 12 weeks of Sof and Ribavirin. Genotype 3, you need 24 weeks. This is just shown here in a slightly different format. Here's genotype 2, 97% for naive non-cirrhotic, 100%, but the numbers here are very small, so you have to take this with a grain of salt. The experienced non-cirrhotic, 91%, and the experienced cirrhotic, 88%. And for genotype 3, even with 24 weeks, the treatment-experienced cirrhotic patients do the poorest, but you get actually pretty decent numbers with 24 weeks for the other groups. So summary of conclusions for the VALENCE studies and for the fission, fusion, and positron study are that 12 weeks of Sof and Riba results in SVR greater than 90% in genotype 2, treatment naive with and without cirrhosis. So that's the genotype 2s do very, very well. The treatment experienced patients with cirrhosis didn't do quite as well. Sofosbuvir and Ribavirin for 12 weeks led to similar results in the genotype 3 patients, and the lowest rates were in those patients with cirrhosis, as we've said. Sof and Ribavirin for 12 weeks is suboptimal for genotype 3, and you really need 24 weeks. Total duration, significantly increased SVR rates. So I think we will never again group genotype 2 and 3 patients together in our clinical trials. They will always be separated. Now, a little bit about Simeprevir. It is a protease inhibitor, like telaprevir and boceprevir are protease inhibitors, and it has antiviral activity over genotypes 1, 2, 4, 5, and 6, and it's one pill once a day. The studies that were completed in phase 3 were QUEST-1 and QUEST-II and PROMISE. QUEST-1 and 2 were in treatment-naive patients. PROMISE was in prior relapsers. And the results showed that whether it was QUEST-1 or QUEST-II, which were a same design but just done at a different time and a different geography, or PROMISE, the relapsers, the results are all around 80% compared to around 50% or a little bit less in the PEG-RIBA control group. So this is shown here by a different mechanism. Again, overall SVR 80%. Now this introduces with and without Q80K. Q80K is a polymorphism that is found in genotype 1A virus, and it confers a lack of response in these patients when Simeprevir is used with interferon and ribavirin. So it's recommended that if you have Q80K, if you have a genotype 1 patient, you measure Q80K, which is commercially available, your results are not going to be as good. You should think of a different regimen. But if you don't have Q80K, or if you're genotype 1B, the results are actually quite good, 85%. So conclusions, highly effective, around 80%, and most patients receiving Simeprevir were able to shorten their duration of therapy to just 24 weeks. Now, the COSMOS study. This is a study that takes Simeprevir and Sofosbuvir together with or without Ribavirin, and the design is either 24 weeks or 12 weeks with Ribavirin or without Ribavirin. And they looked at 2 cohorts, a group of prior null responders with mild disease and a group of treatment naive and prior nulls with more advanced disease. And the results are shown here. I'll just take the top line. Other than this is a little bit counterintuitive. Here's longer duration of therapy, 24 weeks of therapy with Ribavirin did the worst. Everybody else was over 90% sustained response rate. That's in the prior null responders with mild disease. And this is in the patients with more advanced disease, including nulls and naives. And again, virtually all the patients were above 90% sustained response rate. There's some little differences here in relapse or lower level of measurement. So, and then this looks at the cohort 2 by genotype, subtype, and by baseline Q80K polymorphism. And basically what you see, the 24-week treated patients all were 100%. In the 12-week treated patients, if you had Q80K, it wasn't as good in this group with ribavirin, but was 100% in this group without ribavirin. So if you look at the overall data, you see very little difference between with or without Q80K. So when Simeprevir is used with Sofosbuvir, it doesn't seem to make much difference if their Q80K is present or not, or very little difference. So safety summaries, this is Sofosbuvir and ribavirin treatment is well tolerated. Some of the flu-like symptoms that you get with interferon you're familiar with. Some of the other AEs, headache, fatigue, pruritus, similar kinds of things that we saw with the other ones. But I can tell you from my own experience in taking care of a lot of patients on these medicines are really well tolerated. We haven't had anybody stop treatment because of side effects. Now, these are some of the investigational therapies shown here that are in various phase 3 trials. So protease inhibitors, this is an AbbVie drug, Simeprevir with BMS, MK5172 by Merck, another Abbott AbbVie drug, an NS5A inhibitor, Declatosphere with BMS, Ladipazir with Gilead, MK8742 with Merck, and then polymerase inhibitors, Disopivir, another AbbVie, and BMS. So a whole slew of new drugs that are being used in combination with what we've already had or new combinations. And the treatment combinations that I expect we will have by later this year or during next year, maybe even extending a little bit into 2016, is the Abbott 3D regimen with ribavirin. The AbbVie 3D regimen with ribavirin, Ladipazir and Sofosbuvir, a single dose, a single pill combination therapy by Gilead, Simeprevir and Declatosphere with BMS, and Simeprevir for genotype 1B, and Simeprevir with Declatosphere and another NS5A that this BMS drug, I can't remember what class. A non-nuke? Okay. So briefly, we'll go over these results. These are the Sapphire 1 and Sapphire 2 phase 3 studies with the AbbVie regimen, 12 weeks of therapy. So this is genotype 1 treatment naive and treatment experienced on the left and on the right. And you can see everything is above 95%. Everybody does very well. There are very few virologic failures, similar to what we'd seen before. Hardly anybody discontinued for AEs. There was a little bit of viral breakthrough or relapse, but patients did exceptionally well. This paper was published in the New England Journal of Medicine just a few weeks ago. This is Sapphire 1 looking at SVR12 rates in various subpopulations, dividing by gender, race, BMI, fibrosis stage, HCV-RNA. And again, the message is everything is over 95%, over 90%, and most of them over 95%. So conclusions, SVR12 rates are high regardless of subtype, genotype 1A or 1B. The rate of virologic failure was low. The regimen was well tolerated with a low rate of studied drug discontinuation. TURQUOISE-II. This is another AbbVie regimen. This is patients with cirrhosis, compensated cirrhosis, treatment naive and treatment experienced. Again, either 12 weeks or 24 weeks. Phenomenal results, 92% and 96%. This difference was not statistically significantly different, but you might think that maybe you would want to treat patients for a little longer for an extra 4 points. This is turquoise by subtype, genotype 1A, 1B, 12-week arm, 24-week arm, 12-week, 24, 12-week, 24. Again, so 12 weeks in genotype 1A doesn't do as well as 24 weeks with genotype 1B or even 12 weeks with genotype 1B. 1B just generally does a little bit better with these regimens. TURQUOISE-II, these are the prior null responders, genotype 1A, and you see 12 weeks and 24 weeks here. There is a little bit of a difference in SVR12 from 80% up to 92.9% in this regimen. So conclusions, the first dedicated trial of cirrhotic patients, including those often ineligible for clinical trials. They included patients with thrombocytopenia, with hypoalbuminemia, patients that maybe had a little ascites. We usually don't get those patients in trials. Then SVR rates of 92 to 96% with 12 and 24 weeks, and the efficacy and safety is similar to the non-cirrhotics treated with the same regimen. This is truly remarkable. Now, the ION series of studies with the combination of Ribavirin and Sofosbuvir, it's genotype 1 treatment naive, about 16% cirrhotic patients. Look at these results. I mean, you can't make this stuff up. 99, 97, 98, 99. So whether it's 12 weeks or 24 weeks with ribavirin or without ribavirin, the results are phenomenal. So, ION conclusions, fixed dose, it doesn't matter whether adding ribavirin or extending duration doesn't increase SVR12 rates. Cirrhotic patients had rates of 94 to 100% with or without ribavirin. The baseline mutations in NS5A didn't have any impact on SVR. It was safe and well tolerated. Ribavirin actually contributed to some more AEs. Single tablet regimen, fixed dose. They put both of these medicines together into a single pill. Make it easy for us. For 12 weeks, achieved SVR in most genotype 1 previously untreated patients. This is Ribavirin and Sofosbuvir plus or minus ribavirin in treatment-experienced patients with cirrhosis in 20%. Again, phenomenal results. 24 weeks here, a little bit better than 12 weeks, and you could consider whether or not that's enough to make a difference between whether you would treat a patient for 12 weeks or 24 weeks. And of course, this is going to the importance of cost and pricing is going to come into play as we go forward when these medicines are approved. This just looks at with or without cirrhosis. So without cirrhosis in the middle, with cirrhosis on the right, and you see without cirrhosis does better, except for 24 weeks. It doesn't seem to make any difference whether you've got cirrhosis or not. It's a little counterintuitive the way that came out. So ION-2 studies, single tablet fixed dose combination with or without ribavirin resulted in SVR rates ranging from 94 to 99%. Baseline NS5A mutations, again, little effect. Ribavirin didn't improve SVR rates, alter viral kinetics or prevent relapse. Majority of patients who relapsed had cirrhosis, and cirrhotics may benefit from a 24-week duration of treatment. And ribavirin had more AEs and probably is not going to be necessary with this combination. A little bit about Declatosphere and Simeprevir. This for genotype 1B. These are the BMS medications. And here you see viral response as SVR12. In the treatment-naive patients, 90% cure rates. In the non-responders, 82%. And in the ineligible and intolerant group of patients, 82%. So here, achieved SVR rates up to 90% in treatment-naive, 82% non-responders, 83%. These are just with genotype 1B. And the SVR rates are similar in non-cirrhotics and cirrhotics. No difference by age, gender, race, IL-28B. All of those pre-treatment predictors of response that you learned before are probably not so important anymore. It was generally safe and well tolerated. A couple % of patients discontinued. And it's being further evaluated with their other non-NEUT to see if a 3-drug regimen will be better efficacy. Last set of data is the Seaworthy study. These are the series of studies done by Merck with MK5172, a protease inhibitor, and MK8742, an NS5A inhibitor. With or without ribavirin in genotype 1 patients with cirrhosis or previous null response. They kind of picked tough patients. And here you see it's either with or without ribavirin for 12 weeks or for 18 weeks. And once again, you see across the line here, tremendous results. for all three groups, whether it's 12 weeks with ribavirin, 12 weeks with no ribavirin, 18 weeks with ribavirin, 18 weeks with no ribavirin. They all do very, very well. So this combination is something we need to pay attention to as well. And then this is partial responders and null patients with or without cirrhosis. Again, they all do phenomenally well, above 90, even most of them above 95%. So safety for the investigational agents, most AEs are, again, headache, fatigue, insomnia, some diarrhea. Hemoglobin goes down a little bit if there's ribavirin particularly. The AEs are very well tolerated. Again, in my experience with our clinical studies unit, we haven't had anybody stop because of AEs in these. The Cladosphere is safe and well tolerated. The Merck drug's safe and well tolerated as well. So there's three sentences here, or three questions for the end of the talk. The changing paradigm: should the waiting game be over? Should we warehouse patients anymore? We're now treating patients with Sofosbuvir and Simeprevir, or Sofosbuvir and Pegriba, or Sofosbuvir and Ribavirin, and the side effects are relatively mild and the efficacy is great. We're going to be going to therapies with not very many side effects and great efficacy. So maybe we don't need to so-called warehouse patients like we did when we had more toxic therapies and we were waiting for milder therapies. Or maybe we should say we're really waiting for true interferon-free therapies with the AbbVie regimen and the Gilead 2 regimen, and side effects will stay low, efficacy will be even higher. So room for thought to consider whether or not you're going to warehouse patients. These new therapies should be out in the next 6 to 8 months. Have the rules changed in terms of predicting response to therapy? I would say that the pre-treatment predictors of response are much less likely to guide treatment decisions. So IL-28B, gender, race, BMI, insulin resistance, steatosis, all those things that we used to look at before are not as important now. And then finally, how short can you go in terms of duration of therapy? 12 weeks is going to be for most of these regimens. And boy, when we think we used to use interferon for 48 weeks, to think about not using interferon for 12 seems like a holiday. There's one study, one of the ION studies, which went down to 8 weeks and did fairly well with high SVR rates. And there's some very early preliminary data with a trial going down to 6 weeks to see if that can rule the day. So it's good, and it's just getting better. I think that's my last slide, and I'll turn the table back to Dr. Jacobson, unless there are some questions.
Thanks, Bruce, for a great overview. I think one of the overarching themes of your talk is that there are different routes to the same destination, that you can construct using different elements or classes of drugs, regimens that together impose sufficient potency and high barrier to resistance that you can get to SVR in this astonishingly high proportion of the time. One of the questions from Twitter has to do with the pathway to failure with these oral therapies. Do you want to make a distinction between on-treatment breakthrough and relapse being the dominant pathway to failure when these do occur?
Yeah, so so when you look at the fine print on most of these studies, you see just about everybody responding, but there's a few people that don't achieve an SVR. And the SVR is usually achieved in people who either have relapse or have primary virologic failure, or who are lost to follow-up from being in the study. They were non-compliant. They didn't continue in the treatment. They missed a metric. So you have to wonder about, for the relapse, do we know why patients relapse? Have we known why patients relapse for the last 20 or 30 years? So I don't have any special insights as to why these patients might relapse. There was a note in one of the sections about ribavirin didn't change the relapse rate at all. So I don't know why patients relapse. And the other one was virologic non-response. You you have to suspect that maybe there's some fatal mutations that occur, and or resistance mutations that occur, and we just haven't identified them yet. That'll come.
Yeah, to me, one of the most mysterious parts of the story is the disparity that you emphasize between genotypes 2 and 3.
Yeah.
Where you have the same on-treatment viral kinetics of decline with Sofosbuvir-based therapy, for example, but much higher relapse rates for a given duration of therapy,
With
like
the
12
threes,
weeks.
unless you get out to 24 weeks.
We don't know if it's the steatosis that genotype 3 induces or something else that makes it harder to eradicate every last virion. One more tweeted question. I have no idea which is grammatically correct, but just a brief word about how DAAs will be used in post-transplant HCV patients. I think from EASL, it's fair to say that it's beginning to look like we're going to see the same kinds of terrific results with DAAs.
Well, one of the nice things about the Sofosbuvir regimens, there's no drug-drug interactions, so you don't have to worry about the immunosuppressive therapies that you use in your transplant patients. So they'll find a place, and we will successfully cure a lot of patients post-transplant, I think.
Thank you. Okay, we're going to talk about some cases and try to bring out a lot of the points that have been discussed, as well as others. We're going to try to emphasize practicality, decisions we actually face every day in practice, as I'm sure many of you do. And so let's go to the first case. By the way, you have keypads in front of you for our audience response system. We're going to be asking you questions once in a while and discuss your answers. Some of them will be right or wrong, but some of them will be opinion or experience-based questions. Case 1 is of an previously unscreened baby boomer, Mark, a 52-year-old white male evaluated by his primary care doctor for a wellness check, last seen 4 years before, denies risk factors, but undergoes screening for hepatitis C in accordance with the current guidelines that Bruce discussed. He's positive, leading to a PCR, which it always should, a positive ELISA test, with a moderately high viral level and HCV genotype 1b. His father had adult-onset diabetes. The patient has a BMI of 29 with mild hypertension being treated, no history of depression, and drinks modestly. So my first question for the panelists is, what's been the impact of the CDC and U.S. Preventive Service Task Force guidelines on your practice? Are you seeing a steady stream or only slow uptake of this in your practice? Nancy, we'll go down to you.
So we're lucky enough, I'm dual-based. I'm at a university where we have an EPIC system, and we were able to quickly implement a pop-up to our primary care clinic that triaged the primary carers to request screening. Now, there's a lot of pop-ups in that system, so I think that although we tried to request some prioritization, I do think that the PCPs often ignore some of the reminders on some patients, but we had a big influx into our practice. We also have some community practices that we go to, and the uptake has been much slower there. I think that now we are seeing a lot more screening because of the new hype around therapy and that increasing the awareness than we did with the actual CDC recommendations or even the support from the United States Preventive Task Force.
Sherilyn, what's the situation at Hopkins?
So in our group, it's a bit different. We've not seen much uptick in our newly diagnosed Hep C referrals, so it's been slow getting to us. Part of that is the type of patients we tend to get are often referrals from community-based GIs who have more challenging patients. They've failed prior therapy or have complicating comorbidities, but the answer is really no. We haven't seen much.
It's been our experience too. Bruce, some people are talking about offering HCV testing at the time of screening colonoscopy. Do you know anybody who's doing that?
Yeah, I do. One of our gastroenterologists in St. Louis has been doing that, and I think he told me he had screened 600 suburban middle-class baby boomers and hadn't found any hepatitis C. So I think part of it is where you live and what you do, what kind of clientele you're seeing.
As you may know, there's a state law in New York now that mandates HCV screening for baby boomers who are either in the hospital for whatever reason or anybody who's encountered in that age group in a primary care practice. But I think we still haven't seen that really kick in. I think it's going to happen in the next couple of years. So the patient's laboratory values include a normal hemoglobin, platelet count of 153,000, low-grade AST and ALT elevations with the ALT a little higher, and normal albumin, total protein, bilirubin, but his fasting glucose is 120 and his A1C is 6.4%. So he's well up in the pre-diabetic range, and he has a right upper quadrant ultrasound that shows coarse echotexture with a smooth liver contour. I always look for what they say about the contour in ultrasound. So here's your first question. Please pick up your keypads. And the question is, when you assess for liver fibrosis, what is your preferred approach at this time, at least initially? Is it blood and serum testing, with tests like FibroSure, FibroSpect, or APRI, FibroScan, A and B, or liver biopsy? That's very interesting. It's fairly evenly divided across all four choices, and a fair amount of liver biopsies are still being done. Bruce, you and I have been old-time believers in liver biopsy. We've talked about this for many years. How much are you still doing? I know you have a FibroScan machine, right?
We have a FibroScan machine. Of course, we can't get reimbursed for using it, but that causes some consternation amongst some people in the institution. I do fewer liver biopsies than I've done in years. In years past, I might do 5 in a morning, and now I'm doing maybe 1 or none. So not as many liver biopsies being done. But before, I used to use liver biopsy. When we had sustained response rates of 40 or 50%, I used a liver biopsy to help decide if I thought I should really treat that patient. And now, with treatments that work in 90+% of patients, the decision to treat is much easier to make, and I don't need the biopsy to help make that decision. So I use biopsy less frequently. An obvious mild disease patient, you don't need a biopsy. An obvious cirrhotic, you don't need a biopsy. The place where you need a biopsy, in my view, is that person that's kind of in between. Maybe their platelets are 130,000. If they're 60,000, you know that they've got cirrhosis. So I use biopsies much less frequently than before.
Yeah. My liver biopsy volume is probably down over 90%. I've done 5 of them in the last 5 months. I never thought I would say that, but I think we have similar experiences. I'll get Nancy and Sherry Lynn's opinions in just a moment. Now we're doing A and B, but if I had to pick one or the other, I'd rely on my beloved FibroScan machine, which we've had for about 7 months, and I have found to be truly transformative of the way outpatient hepatology is practiced. So, Nancy, would you actually assess Mark's liver for the presence and degree of fibrosis? And if I could generalize that, and Bruce commented on this a little bit, do you think every patient deserves some specific fibrosis assessment, or are there times short of cirrhosis when you're so comfortable, for example, that somebody has mild disease that you don't do anything?
I think that even the statement that you're so sure that there's mild disease that you don't do anything is an assessment of fibrosis. Every single patient needs to be looked at for their risk of progression. And the degree of current fibrosis is probably one of the most accurate ways of assessing future fibrosis progression. I agree with the statement that was already said. Someone who looks obviously cirrhotic and someone who is obviously not cirrhotic probably don't need aggressive, further evaluation. But that gray zone is very big. Cirrhotic individuals can have platelets that are 300. They can be asymptomatic. They can look healthy. And their risk of progression is probably lower than the individual who has platelets of 60. But everyone needs that assessment. I do have some, Jones envy because we do not have a FibroScan. So my volume for biopsy is still down significantly, but it's not because of the magic FibroScan.
Sherilyn, what would you do with this particular patient at Hopkins?
I would want to know. I tend to look at the trend, so I would want to have something to sort of guide me here. And so I would definitely, either do a FibroScan. We also have a FibroScan. We have not been able to roll it out for our entire clinical practice just yet, but or some kind of fibrosis marker blood test, just to have a good sense of kind of where he is. Much like with Nancy, I feel like, my goal is really I need to feel confident that someone does not have cirrhosis. That's ultimately what I care about in the end. I need to know who I need to be monitoring for liver cancer. So I need to feel very comfortable with that information. So I would definitely want to do something to feel confident in either ruling or ruling out cirrhosis.
Okay. Yeah, I feel very strongly actually that as we move into the era of highly curative therapies, that some type of assessment for fibrosis is still going to be necessary, even when you know you're going to treat a patient, because you have to know how to follow them afterward, particularly with regard to HCC surveillance. So I just want to show you a little bit about FibroScan, since its adoption is becoming increasingly widespread in the United States. I think we were something like the 70th country to get approval, but we finally did about a year ago. It has been used extensively in Europe and elsewhere in the world, and basically it's a device that puts pulsed ultrasound waves into the liver and measures the velocity of sound wave transmission through the liver. So I'll go right to the bottom and show you this sloped line here, and I actually like pointing this out to my patients. The idea being that this is telling you how quickly it's taking for that sound wave to travel through a given length of liver, around 6 centimeters. And what's good, I like to emphasize to the patients with a nice slant like this, is that it's taking longer for sound to get through the liver, which is true of a non-fibrotic liver, as opposed to the more rapid transmission of sound, which gives more of a straight line down if the liver is stiff with scar tissue. You end up getting a score in kilopascals, and that's a unit, of course, I'd forgotten existed since high school, if I ever even heard of it then. And you also have to look at something called the IQR interquartile range, which gives you an idea of how reproducible the readings from the 10 pulses that you're supposed to put in are. So what you can see on the top is the Medivir scale and the scores that correspond. And one of the major strengths of this technique is that it's very good at distinguishing cirrhosis from non-cirrhosis. In different sources, you'll see slightly different numbers as the cutoff for cirrhosis. It may be dependent on disease, but it's around 13 to 14 kilopascals. Above that gives you a high level of confidence that cirrhosis is present, and conversely, if it's lower, that cirrhosis is absent. Not perfect, but nothing is, even liver biopsy. His FibroSure score, and this is how we do it at our institution, was 0.62, which is kind of getting into F3. His FibroScan was 8.8 kilopascals. The test has to be done with patients fasting, or you can get an artifactually high result. The recommendation is that patients fast for 4 hours. And if somebody's just had breakfast and we happen to be seeing them in the morning and didn't know we were going to do it until the visit began, we might have to have them come back or wait for a while. And you can see the IQR is 12%. It's supposed to be less than 30%, so this is an acceptable reading. And we would interpret this as moderate fibrosis with a fairly high level of confidence, especially given the other clinical and ultrasound data, that the patient doesn't have cirrhosis. And at the present time, in our clinic, we would not do a liver biopsy on this patient. So an overarching theme here is twofold. First, that hepatitis C is associated with an increase not only in liver-related mortality, but all-cause mortality, and that we have very important studies, including the 2 that I'll show you right now, that show that SVR in response to therapy decreases the risk not only, again, of liver-related mortality, but all-cause mortality. So here's a very important VA study showing that SVR was associated in the population, namely veterans with a lot of comorbidities, associated with a decreased risk of all-cause mortality, and sub-analyses have shown that this pertained to the non-cirrhotics as well, across the major genotypes in the United States, especially in genotype 3, which really in a way is the most pathogenic virus. Not that it's good to have any type of hepatitis C, but study after study recently, including this one that I'm showing you, has suggested that genotype 3 is associated with a uniquely high risk of progression to fibrosis, cirrhosis, and liver cancer within a certain period of time. This is a very important study from JAMA, fairly recently, again showing that in a population with fairly advanced fibrosis, decreases in adverse outcomes, including all-cause mortality, liver-related mortality or transplant, liver cancer, and liver failure, when you attain an SVR with therapy compared to patients who fail to do so. So here's another question for you, which is, in hepatitis C patients with diabetes, which of the following is or are true? First, Antiviral therapy improves renal outcomes. Second, that improves cardiovascular outcomes. Third, that therapy is contraindicated in diabetes. And fourth, choice D, both A and B. Please select. Okay, so we think this is a right or wrong question, and most of you got it right. And I'm going to ask, go to the next slide, Nancy to elaborate on this information.
So I like to say that there's been a long growing understanding that extrahepatic manifestations of Hep C go beyond vasculitis. And the signal of insulin resistance in glycemic control has been growing and growing and growing, and somewhat culminating in this publication that was just recently released in Hepatology. There's a large Taiwanese cohort observational study. This study is limited by the fact that they could test hepatitis C antibody, they could determine diabetes, and they could determine who was treated, but they couldn't actually determine treatment outcome. Now, in Asian countries, the SVR rates for PEG-RIBA are above the 40% that was just quoted here, but the SVR and non-SVR treatment patients could not be separated out. Despite that limitation, this study nicely showed that complications associated with diabetes, such as cardiovascular events, end-stage renal disease, were lower in diabetics with hepatitis C that had Hep C therapy. So I think that there are reasons that we might decide to treat patients above and beyond avoiding liver cancer and transplant.
Thank you. So that gets to our practical question about treating this patient, and I'll go down the panel very quickly. On the basis of the patient's fibrosis alone, would you treat this patient now or defer therapy? And does his prediabetes influence your decision? So, Bruce, maybe you can take that first, and then we'll just go to the others.
I would treat him, and the prediabetes does not influence my decision.
Sure.
It helps it, but it doesn't influence it.
Based on fibrosis, I would want to treat him.
On the basis of the fibrosis, is there any part of you that says maybe you can prevent him from developing overt diabetes by curing him now?
I think that is icing on the cake. So absolutely. I mean, that's more rational, particularly if he's at all hesitant, about moving forward with treatment now. That is certainly something that's part of my discussion with him as to why we should move forward.
And there are several published studies now suggesting that if you look at SVR patients, they get less diabetes in the next few years compared to non-SVR patients. I don't know, Nancy, if somebody this close to diabetes can actually be prevented from developing it, but would it weigh into your thinking?
I mean, I certainly think it's not going to accelerate his diabetes. And I do think that prioritization of therapy is probably fibrosis is probably still one of our strongest motivators. But you certainly want to look at overall quality of life, and glycemic control is incredibly important.
So I, too, would treat this patient now on the basis of both his fibrosis and the thought that although I really don't know whether I can prevent diabetes by curing him 8 months sooner than I might with a regimen in the future, perhaps it's true. And if he developed overt diabetes 9 months from now, I might kick myself for not having tried. But I suppose that's one particular way of thinking about it. And then the final question about this patient is, what would you recommend at this time? Which of these regimens? So let's go in the opposite direction and just pick a regimen and maybe say a brief word. Nancy?
All right. You'll have to, why don't you review for both me and the audience? He's a pre-cirrhotic, naive genotype 1B.
Yes.
Which means that he should have fairly effective outcomes with a lot of the regimens that are on the sheet. In my opinion, I did not hear anything from his case scenario that suggests he would be interferon ineligible or intolerant. So I would probably pick pegylated interferon, ribavirin, and sofosbuvir if I was treating him right now.
Sherlyn?
Same. Again, without a contraindication to interferon, that offers the NEUTRINO regimen offers an excellent opportunity for him to get 3 months of therapy, 90% SVR.
And Bruce, if he said to you, I'd really rather not take interferon, would you engage him in a discussion about Simeprevir and Sofosbuvir? And if he preferred it, what would you do?
I would engage in the discussion before he said it, and I would offer him Simeprevir and Sofosbuvir just to avoid the interferon-related side effects, recognizing that it's an off-label use. feeling that it's better tolerated.
I think one thing we can all agree on is that the combination of Sofosbuvir and Ribavirin would be suboptimal for a genotype 1 patient, although having considerable efficacy, not up to the level of the other options. Okay, let's go to the next case. And by the way, it is approved for interferon ineligible patients, that is 24 weeks of Sof and Riba, but probably not being used very much for that purpose right now. Let's go to the next case, please. So we have Gwen, a 63-year-old African-American female, transfused at the age of 24, many, many years ago, with hypertension, a high BMI, and she has lichen planus, which has actually been associated with hepatitis C. She's married with 2 grown children and a third-grade teacher with pending retirement. She has genotype 1A with a fairly high viral level, an albumin of 3.7, globulins to match, a bilirubin of 0.2, a normal INR, an AST that's a little higher than an ALT, which we always look for as a possible harbinger of more advanced fibrosis, and as if to vindicate that concern, a somewhat low platelet count and a high FibroSure score that gets her into the cirrhosis range associated with that test. She has fatty infiltration of the liver on ultrasound and a mildly nodular liver contour, says the radiologist. So, Sherilyn, would you do anything else to assess the status of this patient's liver disease, or do you think you have enough information?
I think we have enough information to feel comfortable with cirrhosis in this case. We've got a FibroSure test, lab test, low platelet count. She's, her ultrasound suggests nodularity, cirrhosis. So I feel comfortable at this point in terms of determining the degree of fibrosis that she's definitely cirrhotic, which then prompts us into, sort of the next few steps of an evaluation, which means we need to look for cancer, look for esophageal varices, do some other oral hypertension assessments to make sure that we've fully assessed her before we jump into treatment.
Bruce, would you be able to resist putting your FibroScan probe on this patient?
I wouldn't feel that I needed to do it. I'm comfortable with a clinical diagnosis of cirrhosis with the information presented.
Okay. I would, but I can't argue with you that the information is there, and it's compelling. Well, we did one anyway, and it was right at the border, but really just into the cirrhosis range with a low IQR, telling us that it's a reliable reading. And so what are the current treatment options for this patient, Nancy?
To remind you, this is a genotype 1A naive compensated cirrhotic.
Yes.
So she essentially has the same options that case 1 did, with the additional concern that her genotype 1A might have that Q80K abnormality that Dr. Bacon brought up, and so I would like that before I made a confirmed decision on what I would offer her.
Even though there's no clear signal now from the final Cosmos data that it makes a difference, you're still bothered by it a little bit.
Like you getting the FibroScan that you didn't necessarily need, I'm going to get that Q80K that I may not need either.
Yeah, I do it too, but I think we're in the minority. Bruce, I think you have a comment?
I'm not going to do it. Like I didn't do the FibroScan.
Okay.
Yes, but you spent $166,000 on a patient I would have given interferon on, so I still save money in the end.
Does the patient's race or ethnicity play into your thinking? What's the situation with African American patients now in these new regimens? Is there as much of a delta, if any, compared to days of old?
No, it's really remarkable that that was an interferon effect that we saw years ago that just isn't seen with the new DAAs.
Indeed, there are abundant data bearing that out. So, as Bruce showed you in the NEUTRINO study with Ribavirin, 87% of the African American patients had an SVR, really the same as the non-African American patients. And with the 2 major DAA combination studies shown, ION-1 and Sapphire-1, both in treatment-naive populations, but I think the same theme prevailing in treatment-experienced populations, really no impact, which is itself a major advance in the field. So we talked about this a little bit, but let's get some opinion from you. How does the HCV NS3 protease Q80K polymorphism, I won't ask anybody to remind us what Q and what K is, affect treatment response in genotype 1A HCV-infected patients? 20% or more reduction in SVR when Simeprevir is given with Sofosbuvir, more than a 20% reduction when Simeprevir is given with PEG and Riba, reduced sensitivity to all HCV protease inhibitors, or A and B. Please select. So 10% of you thought that there was a more than 20% reduction in SVR in the oral regimen of Simeprevir and Sofosbuvir. And as mentioned in the final analysis of the Cosmos data, you really can't discern an impact at all. In the Cohort 1, the mild fibrotics who were null responders, there were 3 patients who relapsed at the end of the treatment, and they all did have the Q80K, but that impact was not seen in the second cohort of equal size, patients with advanced fibrosis. And I think if there is an impact, it's going to be slight. And I think we need larger studies, such as are being planned at this time, to see if there really is an impact of this polymorphism in an interferon-free regimen. Clearly, B is correct, as Bruce mentioned. It certainly doesn't reduce the sensitivity to other HCV protease inhibitors, and so B was really the correct answer here. So for our panelists, if you decide to treat now, and I think most of us would, which HCV regimen would you recommend? And Sherilyn, let's start with you.
A little bit tougher for me. I think, while I don't know that there's any PEG interferon contraindication, she is a bit older, looking to retire. I don't know where she is in her school year. I would think about, with interferon and ribavirin at all, that could potentially impact her quality of life, her job, some other things. So that's something I want to flesh out a little bit with this particular individual. Also, given that she has advanced fibrosis and cirrhosis, I want to make sure that I'm very comfortable that she's well compensated before I move forward with interferon and ribavirin. Certainly her labs look to be. She's someone that I really would go back and forth between the NEUTRINO, so the triple PEG Riba Sofosbuvir, but also certainly think about Sofosbuvir Simeprevir in her case as well, and really see where she is with this, as part of my decision.
Nancy, your choice?
I think I would come to the same conclusion as Sherilyn, and I would add that although she doesn't technically, like cirrhotics do not tolerate therapy as well. She doesn't have any of the flags, such as low albumin or low platelet count, below the threshold where you would expect that she wouldn't do well on PEG, Riba, and Sofosbuvir. But given the potential and that we probably have one good shot that we want to aim for, I would go for the Cosmos regimen.
Bruce, she says, can't I wait till the fall? I appreciate the offers that you're extending to me. Here are going to be FDA-approved oral regimens in the fall. How much will a 6 or 7 or 8 month delay change the likelihood of my outcome? I wrestle with this all the time.
Yeah, she's had it for 40 years. It's probably not going to change it too much. We obsess over the fact that they're here now and we want to treat them because that's what we do. But in point of fact, a 6-month wait probably isn't going to make any difference. So I would grant her that if she made a strong argument for it. If that wasn't an issue for her, I would recommend that she receive Simeprevir and Sofosbuvir.
So I think what you're saying is even a compensated cirrhotic is likely to do relatively well in the next year. They do walk around with a slight risk of annual risk of getting an HCC, but if you did all the modeling, which I wouldn't know how to do, you'd have to come up with a big number of patients like this to say that by treating them 6 months sooner, you're going to affect their outcome. And yet sitting on a cirrhotic bothers me. Any other comments?
I think that most of us feel that way because when you have a clinic that's augmented with a bunch of cirrhotics that you're monitoring, you do see a lot of liver cancers. You see variceal bleeding. And we're enriched with that just based on what we do on a daily basis. But I do worry, just like sitting you're pre-diabetic, that you're going to wish that you might have done something different.
So if I could use the phrase, I might kick myself again like I did before. If a patient like this had therapy deferred for the better part of the year and got an HCC in 14 months, I might say, gee, I wonder if I could have, or whatever time would be appropriate given the biology of the tumor when it first becomes detected.
Yeah,
and that weighs on me.
I would say she probably already had it.
Well, then 20 months. All right, let's go to another genotype, genotype 3. We've already made some comments on that. We have Priya, a 61-year-old white female with HCP diagnosed over 10 years ago, deferring treatment because of childcare issues, with the PCR showing an HCV RNA level of 490,000, normal hemoglobin, but her platelets are low at 91. Her albumin also is 3.7. Her AST is also a little higher than her ALT, and right upper quadrant ultrasound with nodularity. And here I'd like to get into briefly the practical issues pertaining to cirrhotics and what additional steps you would take before we discuss the treatment issues. So, Bruce, let's start with you.
Well, it would be reasonable to do an endoscopy to look for varices. Alpha-fetoprotein is not a particularly useful test in the age of good imaging. She had an ultrasound done that showed nodularity. They didn't see any masses, so I don't know that you need to do a CT scan or an MRI. I'm quick to do CT scans and MRIs, oftentimes because radiologists say on the ultrasound, well, we saw something funny. We don't know exactly what it is. Maybe you ought to do maybe you ought to do a CT scan. Problem is, then you do the CT scan and they say, well, we saw something funny. Maybe you ought to do an ultrasound. FibroScan, I think you already know she's got cirrhosis, and I don't think a biopsy is necessary or a FibroScan is necessary. So I would do the endoscopy.
I get a baseline CT, preferably MRI, to avoid the radiation exposures, particularly those I anticipate over time, in every cirrhotic at baseline, and it's very common in my practice for us to alternate MRI and ultrasound, or in overweight patients or those with, quote, indeterminate lesions to get an MRI every time. So far, and that's every 6 months, which I admit is a lot, but every 6 months is the recommended frequency, however you do it.
Well, it's recommended every 6 to 12 months, I think. I have a hard time doing it every 6 months, particularly in MRI.
I've had a couple of bad experiences in patients who didn't listen to me and waited 12 months to come back. Anybody else comment on that? Nancy?
Our pre-transplant patients that are listed, we do at least an annual CT or MRI and often semi-annual. But in our stable cirrhotics that are not considering transplant, we still do a fair number of ultrasounds. But I think that our area, the paperwork for pre-certification for the imaging that's not advocated by guidelines still catches up with us.
So an ARS question for all of you. How would you treat this patient? Sofosbuvir and Riba for 12 weeks, Sofriba for 24 weeks, Pegribosol for 12 weeks, or Simeprevir and Ribavirin for 24 weeks? Please select. So B is indeed the FDA-approved regimen for genotype 3 in the United States. But not to be ignored is the third option as well. Suffice it to say, with regard to those who voted for the 12-week course, that simply is not enough for genotype 3 patients, and that's what the phase 3 development program taught us. And for those who chose Simeprevir, please be reminded that Simeprevir is not nearly sufficiently active in genotype 3 to be a viable antiviral agent for patients with that HCV genotype. So as Bruce showed you earlier, if we look at this FDA pooled analysis of genotype 3 patients, and these are treatment-naive patients, 24 weeks is resoundingly superior because of the greater efficacy in preventing relapse, not so much in suppressing virus to undetectability compared to 12 weeks. Now, what if upon further questioning, you got an email, and I've gotten a couple like this, not too many, that tells you, oh, I forgot to tell you, I think about 8 years ago I took peg interferon and ribavirin, or it might come up at the next visit. It's a little hypothetical, I admit, but I do want to talk about treatment-experienced genotype 3 patients. So would this change your recommendation, or would you still go, if you went with Sofriba in the first place, it is the approved regimen for treatment-experienced patients, would you do anything differently? Sherilyn, I think I left you out of the last series of questions, so.
Well, what we haven't yet mentioned is the possibility of Pegribosol-Sofosbuvir for 12 weeks with a patient like this. There has been data that suggest that might be an alternative option for someone who's treatment experienced genotype 3. I think, certainly, again, I've got 2 genotype 3 patients right now on treatment. Both are interferon ineligible due to previous severe side effects with interferon. So sometimes we're forced into making decisions based on treatment experience, but that's certainly the triple regimen is something to look at here as an option. We haven't yet really looked at those details, but that's something to think about.
Let me ask you this. When you give Sofriba, how often are you checking viral levels?
So we are checking viral loads monthly initially. And then once someone is fully suppressed, then we tend to let it go longer in between. But I would say initially I've had some patients that have been slower to respond, so I like getting that monthly viral load. Some are not fully undetectable at week 4. So I want to repeat it.
So far, we've not shown to correlate with ultimate outcome, but I think we're all doing it anyway, and I know many practitioners do it at 2 weeks. Mostly, we all say to ensure compliance. So here are some data on the right. I've already shown you the left side of this slide, but if you look at the pooled data from treatment-experienced patients, also 24 weeks of Sofriba is clearly superior. And if we look at that 77% and break it down on the left side of this slide into non-cirrhotics or cirrhotics, we see that cirrhotics hit a bar of some kind. They can't get above 60%, even with 24 weeks of therapy, because that was the SVR rate in the treatment-experienced genotype 3 cirrhotics in the FUSION study, given 16 weeks of therapy as well. So there's some biology going on here in terms of the host-virus interaction that really is proving an obstacle, again, based on both host and viral factors in this particular population. Not that a 60% SVR rate is something to be ignored, and indeed, I feel strongly that every genotype 3 patient in my practice, including but not only the cirrhotics, should be treated. But Sherilyn raised the interferon question, and there are 2 pieces of data that do make the idea of interferon with Riba and Sof certainly viable, if not overtly attractive in this population. A small study, admittedly, from Eric Lawitz, showing that in treatment-experienced cirrhotics or non-cirrhotics in the Lone Star 2 trial given 12 weeks of peg-riba-sof, 83%. Now, of course, you can't compare the 83% on the right to the 60% on the left. It's statistically not valid, but a suggestion at least. And then another study presented by Professor Esteban just a few weeks ago in London, looking at people who had taken less than 24 weeks of Sofriba with genotype 3 and failed by relapse, which again is virtually the only pathway to failure with Sof-based therapy. And peg-riba-sof for 12 weeks, shown in blue, did better than Sof and Riba for 24 weeks in both non-cirrhotics and cirrhotics. And this makes you wonder whether peg-riba-sof is indeed not quite an attractive option, not only in the cirrhotic genotype 3 treatment-experienced patients, but maybe in genotype 3 in general. And I believe that actually that regimen is one of the approved regimens in Europe for genotype 3, but not on label here in the United States. So I think I'd like to go on to the next case and try to get back to the questions in a little bit. So here we have another patient with advanced fibrosis, a prior peg-riba failure and non-responder, a 43-year-old man named Bill with longstanding HCV who stopped drinking heavily a number of years ago, fortunately, and has mild untreated depression. But he is a cirrhotic, dating from a liver biopsy in 2007, and unfortunately he was a null responder to peg-riba in 2008 with debilitating depression. He has a high viral level. He's genotype 1A, fairly active disease from his transaminases, an albumin that's borderline, bilirubin of 1.1, platelets of 119, another ultrasound in a patient in whom I personally would also get an MRI at this point, and no varices on a screening EGD. He's very anxious to be retreated now. You can hardly blame him. And so I'll ask the panel, I'll ask you, actually, which of the following applies to HCV genotype 1 cirrhotic null responders? And I'll read you through this one because it's a little detailed. But A, the addition of Ribavirin to Ribavirin, the NS5A inhibitor plus Sofosbuvir, does not significantly improve SVR rates. B, The extension of Ribavirin and SOF treatment to 24 weeks in cirrhotics may improve SVR rates over those observed at 12 weeks, and this would be referring to the ION-2 study. ABT 450, Umbidisvir, and Tisabivir and Ribavirin for 24 versus 12 weeks may improve SVR rates in genotype 1A null responders to previous interferon therapy, or all of the above. Please select. So there's a resounding opinion that the answer D is the correct one. I almost said genotype D, and that's correct. The data don't suggest that the addition of Ribavirin to Ladipizir and SOF increases SVR rates with that regimen. From ION-2, there's a suggestion, although the study wasn't powered to answer this definitively, that 24 weeks may be better in cirrhotics than 12 weeks in terms of the SVR rates. And Bruce showed you a slide from the TURQUOISE-II study clearly indicating with the 80 versus 93%, a signal at least that 24 weeks may be preferable to 12 weeks to optimize the chance of SVR. So a question for the panel, which is what treatment would you recommend for this patient? And Bruce, we'll start with you and go to the left.
Okay, so again, let's summarize. It's cirrhotic, long-standing Hep C, cirrhotic, high viral load, genotype 1A.
Yes.
Well, I sound like a broken record, but I would use Simeprevir, Sofosbuvir again in this guy. I'd keep him away from the interferon. He had debilitating depression with interferon
He's
before.
Really
yeah.
interferon
So he's not he's interferon ineligible. Then the choice is easy.
Okay.
For me.
Do we all agree on this one?
Yeah, I'll give it to Bruce.
Nancy?
Yeah, I think that the only other thing you could consider would be deferring treatment for another regimen. But it would either be the Simeprevir, Sofosbuvir combination, or waiting for better things.
And for completeness, again, let's remember that for interferon-ineligible patients with genotype 1, SOF-RIBA is an approved option in the label for 24 weeks. But the data in cirrhotics and in null responders aren't all that encouraging from phase 2, and the one phase 3 trial that I think we'll show you very briefly toward the end, which was in co-infected subjects, showed very nice SVR rates of about 76% in treatment-naive patients, but they were almost all non-cirrhotic. So I think Sim-SOF would be the way to go here. I would agree. Now let's talk about a protease inhibitor failure. I'll bet many of you have some of these patients in your practice. So let's talk about Mary, who's a 67-year-old woman with cirrhosis, genotype 1B. She relapsed after a course of PEG-RIBA and subsequently, unfortunately, to a 48-week course of PEG-RIBA-Simeprevir 2 years ago. She has an ALT of 81 with an albumin of 3.4. This is a real patient from my practice, and the platelets are rather high, surprisingly, but they're normal at 201,000. Surprisingly, because her MRI recently has shown she has cirrhosis, and she's very eager to be treated and does not wish to defer consideration of therapy. So a protease inhibitor relapser. And a question for all of you is, in HCV patients who failed a prior protease inhibitor plus PEG-RIBA treatment, A, retreatment with PEG-RIBA-SOF can achieve high response rates. B, prior exposure to a protease inhibitor should not affect retreatment with another protease inhibitor. C, retreatment with SOF and an NS5A inhibitor can achieve high response rates. Or D, A and C. Please select. So I think all the panelists would agree with those who chose D. Retreatment with PEG-RIBA and SOF can, as I'll show you in a second, achieve high response rates. We've really just found that out relatively recently. Prior exposure to a PI may very well affect retreatment with another protease inhibitor. More about that in a second. And retreatment with Sofosbuvir and an NS5A inhibitor can indeed achieve high response rates. So here are the data. I'll just go on. I'll show you the data in a moment. I think the question du jour for these patients is, would we order a commercially available sequencing assay, such as GenoSure, there is at least one other, to assess for PI-resistant variants to help guide you as to whether retreatment with a PI-containing regimen might be efficacious. So what are the opinions on that? Nancy?
Well, I think that my hesitancy in this is that if you saw the resistance, you would probably use that information to help design the next round of therapy. However, if you didn't see any resistance, you would assume that a patient who had failed Simeprevir in the past certainly had resistance develop. And I would worry with a commercial assay that the resistance was there, but at a level where I couldn't actually measure it. So that I would maybe hesitate not order this, because I would probably avoid a regimen where I thought resistance would impact my decision.
So what you're saying is that GenoSure is a population sequencing assay, and that 20% of your virus has to be that variant to detect it. And I think you're saying that it could be 5 or 10%, which might affect, let's say, retreatment with Simeprevir or Sofosbuvir, and we just don't know.
Yes.
And so that would make you uncomfortable. Any other comments on that? Okay. So we did a GenoSure assay already almost a year ago, and she had no PI resistance variants. And Nancy's right, but sometimes, particularly relapsers to PI-based therapy, don't have resistant variants, although the majority do. So we don't know if she ever had them. That was about half a year after she completed her course and relapsed. And I think we've already addressed the next question, which is that perhaps none of us would still be terribly confident using another protease inhibitor with cross-resistance. So I'd just like the panelists to briefly tell me what to do with this patient, because she was just in my office last week. Sherilyn?
You know, I really like the idea of deferring for a regimen like Sofosbuvir or Ribavirin, because it offers her, I think, a really the strongest potential for a high SVR. And she's been through so much interferon and ribavirin, and it just hasn't been effective. And I guess the thought of going back on PEG-RIBA with Sofosbuvir, I lose faith in PEG-RIBA at some point after someone's been through it so much. So that's kind of where I'm looking is ahead.
Bruce?
I would either defer, or I'd sort of play it out with her and see what she wants to do. If she's eager for treatment, the treatment is a neutrino regimen versus deferral. So I would see where she weighs in.
Okay. So this is a study that I'll actually have the privilege of presenting tomorrow morning at a plenary session, but it was also presented at AASLD by Professor Pole from France. And it looked at the neutrino regimen, as Bruce alluded to, in patients who had failed prior therapy with a protease inhibitor plus minus at least one other antiviral. And the bottom line is that nearly 3/4 of the patients, at least in this interim analysis, have had an SVR so far. So this vindicates what I believe Nancy or the AASLD IDSA guidelines, saying that if you're going to treat a PI failure, right now this is the way to do it. On the other hand, it's very clear that therapy with regimens that don't contain a protease inhibitor can achieve remarkably high rates of success. Basically, if you give an NS5A inhibitor and Sofosbuvir, the drugs don't care what virus is there. It could be abounding with PI-resistant variants, and it doesn't matter, as you can see by these very high success rates across the board. Now, I don't think we have time for the last case, but I do want to give Sherilyn a chance to bring out a couple of important points. And if you'll forgive me for jumping a little bit, I did want to get to this point, Sherilyn, of whether HIV-HCV co-infection is still a difficult to cure or difficult to treat population in light of recent data. So perhaps you could address that.
Well, this is a very exciting area. I think for my particular patient population, I live and work in Baltimore City. So there are two things that are incredibly exciting for my practice. One is what Bruce presented, the information about race and ethnicity really no longer being an issue for our patients. We have a large inner city African American population in Baltimore. And so now I can really truthfully say to my patients, race is no longer an issue with new therapies. And I can also say to my co-infected patients that no longer is HIV
a negative factor for Hep C treatment success. So what we're seeing with new therapies, direct-acting antivirals, is it really does overcome those barriers to success that we have always seen in our HIV patients. So we really are seeing SVRs on par with our mono-infected patients today. So it's incredibly exciting.
And I think we have if we can just go past that question, to look at the options for managing co-infected patients. So these are the approved options with the NEUTRINO. Current label makes no distinction, at least for Sofosbuvir, between HIV co-infected patients and other people, and there are excellent results both with Peg-Riba-Sofosbuvir, Peg-Riba-Simeprevir, also Faldaprevir, and as yet unapproved protease inhibitor, and indeed with Telaprevir and Boceprevir. We had begun to learn from published and some unpublished data that there's really no distinction essentially in SVR rates in HIV co-infected people. And as you can see on the right, we're beginning to see the same theme emerge really resoundingly with the interferon-free regimen. So another important advance in the field, leveling the opportunity, the playing field in terms of opportunity for SVR across broad patient populations. I think, Sherilyn, the one thing we can agree on, however, is that at least with some regimens, drug-drug interactions do have to be paid attention to. So maybe you want to just comment on this slide, please.
So this slide really highlights some of the differences in drug-drug interactions between different DAAs available today and in the future. And I think particularly Simeprevir is a protease inhibitor, and as you can see listed, multiple drug interactions with HIV antiretrovirals really having to do with the use of the CYP3A pathway for metabolism and the drug interactions there. I think this is going to be the theme in the future in co-infection. It's not going to be SVR rates. It's not going to be, some of the things that we've seen in the past. It's really going to be this DDI, drug-drug interaction issue that we're going to have to pay particular attention to moving forward in HIV.
So I'd like to go to the first of some concluding slides, actually just 3 of them, but in the meantime give you 2 more questions that have been tweeted or twitted to us. We've talked a lot about patients tonight in our cases with relatively advanced fibrosis. We truly could spend all night talking about deferring therapy for people with mild disease, and that's something that confronts us every day. So I'd like to give the person who sent this important question an opportunity to get the answer. Let's focus, for example, or for a moment on which patients you really do feel comfortable deferring therapy. And we talked a lot about moderate fibrosis and advanced fibrosis. Bruce, are you comfortable? You said really that you're pretty proactive about treating all your patients now, but what about a patient with F1 or early F2 who's had long-standing disease?
Well, I go ahead and offer them treatment. These patients are usually, again, my practice is one of a large number of patients who've failed therapy numerous times before, and they want to be treated. And so if I say to them with, say, either the NEUTRINO regimen or the Sofosbuvir-Simeprevir regimen, a 90% cure rate, or I say, well, we could wait another year or 6 months and get to 95%, not that much of a difference. Some of those patients say, yes, I'll wait. Some of those patients say, I want to be treated now. I want to be done with this. The other thing I would say is we don't only treat hepatitis C to treat fibrosis. We treat other complications that occur. Most notably, patients don't want to have hepatitis C anymore, and they don't want the stigma associated with it, and they don't want the side effects of viremia. One of the things I've noted in the first month of treatment when patients are negative, they come back for a 1-month visit, and I've had many patients say, I haven't felt this good in years, and they're still on treatment. Now, when they were on treatment with interferon before, they didn't say that. They said, I haven't felt this bad, and why did you do this to me? I think we've often underestimated the significance of the side effects of viremia, and patients aren't aware of it because they've been like this for years. And once they get away from it, it really makes a difference for them. So there's other reasons than just retarding or slowing or stopping fibrosis to treat patients.
Nancy, from our conversation yesterday, I gathered you might have a somewhat different perspective on deferral of therapy for these mild patients. What do you think?
I definitely think that we prioritize treatment, partially because we have a little bit of a bottleneck in who we can triage into treatment. And I actually use age a little bit more. I think that if you're a young person who has less baseline predictors that suggest that you're at risk for advanced fibrosis, I'm more likely to discuss deferral of therapy until something else comes out, or it's a little less expensive than a person who might be, 62 or 65 and has, stage 2 disease. I think that there are patients who can safely still defer.
Sherilyn, I come to you with hepatitis C, let's say. I probably got it 30 years ago. Liver biopsy shows early F2, no bridging at all. Great synthetic function, normal platelets. What are you going to do for me? Or to me?
I have to say, unless there's something, some reason, I had a patient recently, newly diagnosed, and I can't remember why we had an IL-28B genotype on this patient, because we're not ordering those routinely, but we do, and he's a CC and a very sort of high-strung, high-anxiety individual, and so we just jumped right into triple therapy with, the NEUTRINO regimen. But as I would say in general, right about now, I'm actually holding a lot of patients, not without a good conversation about what we have right here now, what SVR rates are, what we're looking at, but I think I'm going forward with the landscape a little bit and giving them timelines, and I most of the time, I think with my milder fibrotics, they're waiting.
Yeah, I'll say that also. We're deferring therapy in the majority of our mild fibrotics.
When we warehoused patients when we had Telaprevir and Boceprevir, and we warehoused patients waiting for the era that we're in now, I used to say, when would you start waiting? And I said, well, the length of time before the new treatment was going to occur that it would take to finish the other treatment. In other words, if the new treatment's available in November, say, and it takes 3 months to treat someone, I would stop treating with the current regimen in August. Okay, and what I used to do before with Telaprevir, Boceprevir would be to wait a year, because some of those patients were on interferon for a year.
Can I?
For what that's worth.
Of course.
Sorry. I think that the difference between a genotype 1, 2, 4, 5, and 6 is a little different than warehousing a genotype 3. Our future drug arsenal for genotype 3s is not the same. So I think my decision making is different for those patients.
So just my little anecdote about the word warehouse. I spoke to a newspaper reporter a year ago who called me and asked if I'm warehousing my patients in the context of hepatitis C therapy. I said, well, I don't like the word warehouse because I don't like to describe people that way, as going into a warehouse, even though it's proverbial. So I don't like to use that term. And then I proceeded to tell him that I'm indeed deferring therapy in a lot of people. That was a year ago. Sure enough, in the paper the next day, the story came out, Ira Jacobson, MD at Weill Cornell, is warehousing a lot of his patients. And that's the last phone call that I've taken from a reporter. So I'd like to make just very brief concluding remarks. I thank you for your indulgence as we've gone a little bit over this evening. But again, the theme of many routes to the same destination with these remarkably high rates of genotype 1 associated SVRs. We worried 2 years ago that the 1Bs might do better than the 1As with the earlier regimens, and that no responders to interferon for some reason might not respond terribly well to interferon-free regimens. But that's pretty much gone now. And the reason I make a distinction in terms of many routes to the same destination between nuke and non-nuke-containing regimens is simply the idea that nucleotides have individually a high barrier to resistance, but clearly very potent and high-resistance barrier regimens, cumulatively high-resistance barrier regimens, can be constructed from agents that individually may not have as high a resistance barrier as the nucleotide. So we can get to our destination by any number of ways, and we are going to be having very labor-intensive conversations in our own minds and with patients in the next several years about what regimen to choose. But it'll be in an entirely different context than the quintessential question of whether to use interferon at all or whether to start therapy that we've been engaged in for all these years. So we have a fundamental change in mindset coming, and for some of us already here, no more watching and waiting, to no reason to wait, and I think this will be the mindset in the very near future if it isn't already. And I regard the treatment of hepatitis C universally as a medical and moral imperative, because patients are at risk for three sets of problems: liver-related problems, systemic problems, and I think it was Nancy who emphasized earlier the systemic consequences of hepatitis C, ranging from a higher risk of diabetes to cryoglobulinemia. You only need to see one patient go to renal failure from MPGN related to HCV-associated cryoglobulinemia to never forget it. Lymphomas, non-Hodgkin's B-cell lymphomas, which are the end product of B-cell proliferation that HCV seemingly can induce. New evidence that atherosclerosis may be accelerated in HCV patients. Certainly systemic symptoms are common, though not universal. Depression and even cognitive disorders. And finally, from a public health point of view, of course, ultimately it will help to markedly reduce or eliminate the whole problem of transmission in populations if we can eradicate hepatitis C therapeutically. So I hope and pray that access and cost issues will not hinder our ability to treat all of our hep C patients starting in the very near future, both in this country and elsewhere. I'd like to thank the panelists for an excellent discussion with succinct but very on-target remarks in response to all the questions that I posed to you. I hope you've gotten a lot of information out of this and enjoyed the program, and I wish you all a good evening and a good meeting. Have a good night.